You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for April 16th, 2021. This week, COVID, vaccine-related clotting, a correction, vitamin D, anticoagulation strategies before PCI, and a very good intervention at end of life. First, COVID. The United States seems in a plateau, but with a handful of troublesome hotspots, Michigan most notably. The UK curve looks amazing, and of course the New England Journal of Medicine published real-world data from Israel showing that vaccinating rapidly and the most vulnerable has dramatically beneficial effects. The sad news is the global rise in cases and deaths in India, Brazil, Turkey, some EU countries, and Canada. Numerous Canadian friends tell me of a slow vaccine rollout there, which is weird because it's always seemed to me that the Canadian healthcare system is the most ideal. Now, once again, there was another big bad piece of vaccine news this week. The U.S. paused use of the J&J vaccine due to 6 severe clotting cases. Now, this has dominated health news, and I'll keep it brief. All these reports occurred among women between the ages of 18 and 48, and symptoms occurred 6 to 13 days after vaccination. From what I have read, the reactions are similar to the other adenovirus platform AstraZeneca vaccine mechanism. This is an atypical hit-like issue. Now, I don't see patients with cerebral venous sinus thrombosis, but a hematologist told me it is terrible times 100. All of the J&J related cases have also had thrombocytopenia. Again, there are numbers here to consider. As of the taping of this podcast, there were just 6 reports. And some news stories say there are 6 cases and 7 million doses given, but I don't think that is exactly right. Since all cases occurred in young females, a more accurate denominator might be the 1.4 million doses of J&J vaccine given in this age group. But still, it seems like a very low incidence, but is likely the lower bound as the vaccine was only paused this week. And social media and media is full up with different policy takes on how to handle the rare but horrific complications. The utilitarian take is to obviously continue giving the vaccine. But for this podcast, I want to focus on individual decision-making because it resembles medical decisions. Young people in this age category now have to balance the risk from getting COVID versus the risk for a life-threatening clotting cascade. I'm not foolish enough to try to figure out the COVID-related risk of death or morbidity in a healthy young person. Suffice to say that both the risk of COVID and the risk of this vaccine adverse effect to a young and otherwise healthy person are very, very low enough for it to almost be a wash, especially since in many countries the messenger RNA vaccines will eventually become available. My friend Vinay Prasad made a good point on Twitter regarding the psychology of individual decision-making. It has to do with rolling dice. A vaccine is like one roll of the dice, but taking a chance on getting COVID is like 2 rolls of the dice. Getting COVID and having something bad happen. Many people will pick 2 rolls of the dice in sequence. And I would add to that there are also degrees of stochasticity to consider. Stochastic meaning randomly determined but not precisely predictable. Severe COVID is definitely stochastic, unpredictable. But even more stochastic is the chance of cerebral venous sinus thrombosis after a vaccine. A person will feel the risk from COVID is somewhat modifiable, right? They can be more careful, avoid crowds, wear a mask. But with the AstraZeneca or J&J vaccine, it is pure chance. You get the shot and you wait. Now, this news makes the podcast because rare but severe reactions of now 2 vaccines will A, have major implications globally as it slows the rate of vaccine uptake and will surely slow the ending of the pandemic, and B, it should also allow for more rational discussion over vaccinating lower risk groups like children, for instance. Second topic today is a correction and a comment. I want to make a correction on last week's podcast, and I want to thank Dr. Sasha Salzberg, who pointed out that I mistakenly said in my concluding remarks on the CONVERGE trial that the convergent procedure was open chest. It was not. It involves subxiphoid incisions and pericardial drains, but is not open chest. Thanks, Dr. Salzberg, for listening so closely. Now, he also wrote that minimally invasive surgical aortic valve replacement was common in Europe and that I should be more careful about citing anecdotes from my geography. Indeed, that is true. Going forward, I will be mindful about qualifying any anecdotes as anecdotal. Now, if you want to leave a comment, and I hope you do, just go to the This Week in Cardiology link at the heart.org Medscape Cardiology webpage and click on the comments there. Gosh, I really appreciate the feedback, good or bad. Next topic is vitamin D screening. JAMA published their latest recommendation against screening for vitamin D. This is based on a recent systematic review of the benefits and harms of screening and, of course, early treatment of vitamin D deficiency in asymptomatic adults. Their review found no studies that directly evaluated the benefits of screening for vitamin D deficiency, but that systematic review did find 26 trials, RCTs, that evaluated the effectiveness of treatment of vitamin D deficiency with supplementation. Quote, among asymptomatic community-dwelling populations with low vitamin D levels, the evidence suggests that treatment with vitamin D has no effect on mortality or the incidence of fractures, falls, depression, diabetes, cardiovascular disease, cancer, or adverse events. Now, I realize that vitamin D may seem tangential to cardiology, but I cover this topic for 3 reasons. First, This Week in Cardiology carries great respect for the United States Preventative Services Task Force. This is where the review came from. USPSTF is made up of 16 volunteer members who come from the fields of preventive medicine and primary care. In other words, these are generalists who are good at critical appraisal. Most of these people are practicing clinicians. Now, no human comes free of bias, but USPSTF gets pretty close. And I see this group as a model for Professional Society Guidelines Committee, which should have fewer content experts and more generalists with expertise in evidence review. The second reason I cover this is just because a level of something in the body is low, and that low level associates with worse outcomes, that does not mean replacing it improves outcomes. The best analogy here is HDL. High HDL generally associates with good outcomes, low HDL with bad outcomes, but no HDL raising agent has passed muster in a clinical trial. And to the learners who listen to this podcast, and I appreciate that you do, always, and I mean always, be suspicious of doing things just because it makes sense. Medicine is replete with medical reversals of practices that were done because it made sense. PVC suppression with antiarrhythmic drugs after MI, for instance. Now, the third reason to cover this story is because this podcast worries a lot about distraction and pill burden. The value in not doing things that don't work is that you have more time for important stuff that does work. And of course, it is always good for adults to swallow fewer tablets. Okay, next topic is to hold or continue anticoagulation before an unplanned PCI. Jack Interventions has published a nice observational study from the Sweetheart Registry looking at outcomes in 2 anticoagulation management strategies before an unplanned PCI. Well, this is an increasingly important question because more and more patients are treated with oral anticoagulation, usually for AFib. Estimates have it about 1 in 10 patients referred for PCI are taking oral anticoagulants already. And there are no RCTs addressing the ideal peri-procedural strategy of antithrombotic medicines. The first decision, of course, is obviously whether or not to continue the oral anticoagulant or interrupt the oral anticoagulant before the coronary angiography and procedure. Holding the anticoagulation may decrease the risk of bleeding as patients will not be on dual antiplatelet therapy and anticoagulation, so-called triple therapy. But holding the anticoagulation may also increase the risk of stroke from AFib as well as delay the revascularization after an acute coronary syndrome. And European and American guidelines actually differ in their suggestions. ESC has suggested uninterrupted strategy as the preferred approach, but a 2017 AHA statement still says to discontinue the oral anticoagulation. So, using the Sweetheart Registry, first author Dimitrios Vanastamos and numerous colleagues compared the efficacy and safety of uninterrupted versus interrupted oral anticoagulation strategy in patients who were already on the anticoagulant and were undergoing an unplanned coronary angiography and revascularization. This was a 12-year period between 2005 and 2017. About 3,300 patients had their anticoagulation interrupted, and 3,100 had uninterrupted anticoagulation. Now, of course, this wasn't a randomized comparison, but interestingly, the baseline characteristics were not terribly mismatched. The authors did the usual thing, and they did propensity matching to attempt to get more balance in the covariates of the two groups. And major adverse cardiac outcomes, MACE, occurred in 8.2% in both groups, and the Kaplan-Meier curves are superimposed, so no difference. Major bleeds, 5.6% versus 6.0% in both the groups respectively, so not much different. The authors also found no significant interaction between the type of oral anticoagulation that patients were on arrival, that is, warfarin versus DOACs. This was in terms of the outcome measures, major adverse cardiac events, but notably more than 80% of both groups were on warfarin at the time of presentation. And as you would expect, length of stay was longer in the interrupted anticoagulation strategy, 5 versus 4 days. So my comments are that as the prevalence of AFib increases, these peri-procedural decisions are going to be an increasingly common issue. And the best way to answer the question, of course, is with a trial. And in fact, we have two pretty good trials like this in electrophysiology. The Bruce Control 1 and 2 trials found no advantage to interrupting oral anticoagulation before device implantation. So these can be done. But in the absence of RCT data, the Sweetheart Registry is at least some data. And I say this next statement with great caution, but this looks to be a notch above many other observational studies. And of course, yes, without randomization, there could be confounding. But on the other hand, neither group here looked better. The lack of major differences in baseline characteristics also suggests, at least qualitatively, that the two groups were somewhat similar. The fact that most of these patients were on warfarin makes this data hard to extrapolate to the DOACs. I think we can at least say that this large real-world data set suggests equipoise in the two strategies. To me, I think the uninterrupted oral anticoagulation strategy would seem to be the better default, the control arm, if you will, mainly because it is the simpler, less intrusive strategy. Uninterrupted oral anticoagulation also results in shorter hospital stays, which is a positive for cost and probably safety. Now, you know this podcast warns often about making causal inferences from non-randomized data. But this is a better than average observational evidence, and it supports doing a pragmatic RCT like the Bruce control trials in electrophysiology. MACE and bleeding outcomes in such a high-risk group will occur mostly in the short term, and to me it wouldn't be a terribly costly trial to run. Final topic today is an excellent, superb intervention at end of life. Now, while observational studies are not ideal for causal inference, they are very good for documenting trends in care. They can tell us what we are doing. The Journal of the American Heart Association published an observational study on the use of comfort care interventions after ischemic stroke. First author, Dr. Christy Chu from the University of Texas and colleagues used a national inpatient survey from 2006 to 2015 to assess 10-year trends in the use of comfort care after an ischemic stroke. Now, this was a huge sample of 4.2 million stroke encounters. In total, 3.8% used comfort care. And the good news is that these comfort care interventions increased over time with a decreasing proportion of patients on comfort care who are dying in the hospital after stroke. Notable was that this increase occurred alongside the rise in interventional stroke care. But there were some concerning trends in this study. Mainly, there were disparities in the use of comfort care interventions. Age, for instance, was a barrier. Less than half of the decedents under age 60 received comfort care, while all those greater than 90 years old received comfort care. Now, obviously, younger people will more often pursue life-prolonging care, but less than half of a group dying without palliative support is concerning. Comfort care was also more common in white patients compared with other racial groups. This finding is consistent with previous studies showing that Black patients with serious illness have lower rates of advanced care planning, palliative care use, and end-of-life discussions. Now, there are many reasons why these disparities exist, but since I consider comfort care interventions one of the most important things a doctor can do, I see this as a serious concern and a matter for much reflection. The authors also observed geographic disparities with lower rates of comfort care interventions in the Northeast and South, but better in the West. And again, I don't know why this would be, but variation in something this important also seems worthy of reflection. I highlight this study because it emphasizes some of the most important notions in all of modern medicine. A, all of our patients will die. And while hope is often an important feeling to maintain, it is definitely not a plan for end of life. B, the oath of Maimonides calls on doctors to look after the life and the death of our patients. And C, I note this study because I loved the naming in this study. Calling the relief of suffering a comfort care intervention is perfect. It's like the opposite of saying going palliative or withdrawing care. Friends, if you remember one thing from this podcast, remember that the choice to pursue comfort care interventions at the end of life is to simply choose a different goal. In life-prolonging care, the goal is to extend life. In comfort care, the goal is to relieve symptoms so as to improve the quality of life. Comfort care intervention never equates to giving up or withdrawing care. It is simply to change the goal to relief of symptoms and suffering, not only of the patient, but also his or her loved ones. It is one of the most meaningful things we can do, and I wish I was better at it. So that's it for this week in cardiology. As always, I'm grateful that you listened. And remember, if you like this podcast, please take the time to give us a rating, write us a review. These really help others find us. Until next week, this is John Mandrola from theheart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org on Medscape.